Thank you so much, Nancy and Stacy, for supporting this and inviting me. And thank you to Jill and everyone on your team. I'm really happy to speak about something I have a lot of passion about. And the slides work, so that's good. These are I have no conflicts of interest. I do have funding, which you'll hear more about. And because we are all here, because we care about people, or as my son would say, we care about humans, I'm going to start with a story. I first met Juanita in the 1990s. She was a 90-year-old woman in our primary care practice where we were doing a special project in California for care managers, where advanced practice geriatric care managers, I was a clinical nurse specialist at the time, followed older adults across settings of care. And I know that transitions is one of your topics right now. We were only about 2 weeks into this special project, and I received a phone call telling me that Juanita, someone is saying they can't hear anything in the chat, so just letting you know that to check that Juanita, who I had not even met yet, had been admitted to a psychiatric unit on a 72-hour hold after she had pulled the fire alarm in her low-income apartment building and was directing traffic in her nightgown. Juanita, like many older adults who lived to be in their 90s, had several chronic conditions, but was doing pretty well. She had hearing loss, arthritis, urinary incontinence. She was a formal retail person and had also worked as a telephone circuit board operator during World War II. What we came to know about that day and days later, when Juanita was admitted for this 72-hour hold and I came to the hospital to see her, was that among her conditions, she also had an unrecognized mild to moderate dementia that had never been assessed. And on that particular day, she became acutely confused with a delirium on top of her dementia. This is also known as delirium superimposed on dementia, and you'll hear that a couple of times today. What mattered to Juanita was being able to go out to lunch with her friends and stay independent in her home. But that particular day, she was afraid, and many days probably, she was afraid that she would be incontinent while out to lunch. And again, she had unrecognized dementia. She was on oxybutynin, which is a strong anticholinergic medication. Think Beers criteria, we could talk about that later. That's on the 2023 Beers criteria. I think it's been on there for a long time. And because she was worried about her incontinence, she doubled her dose, and she was also dehydrated that day. And she ended up with a reversible and preventable delirium, again on top of her dementia. Couple things about this case. Her delirium was multi-causal, which you'll find out in a minute is often very common, from things like medication, underlying vulnerability from having dementia, and dehydration, which is extremely common in the long-term care setting. Thankfully, our team and myself was able to get to know Juanita over a period of about 2 years, and her story did not end there. She went from home to the hospital, back home to rehab, and eventually in a nursing home setting where she lived till the end of her life. Initially, we were able to work with the Area Agency on Aging and the Home Health Agency. We got a nurse involved, a social worker. We did a home assessment, had an aide coming in 3 times a week, helped her with ADLs, things like grocery, eating, and hydrating. Again, she was dehydrated that day. And we were able to reconnect her with her son, who she had been estranged with, which became very important when she went into the nursing home facility. So as you can see, she had lots of transitions. And this is not just a story, it's a reflection of what we often see, and we're still seeing 30 years later. And it's supported by research evidence. And a couple of things is many people who have delirium, dementia, and mental health issues, particularly older adults or people with intellectual and developmental disabilities that you might see in long-term care, do not get a diagnosis and may lack support and access to an interprofessional team. A study by Joshua Chodosh and others in the United States found that PCPs were unaware of dementia in over 40% of cases. And this was more pronounced in those with low education and minorities in rural settings. The other thing I hope her case illustrates is that cognitive impairment, again, can have a variety of causes. Many of them are reversible. Most of the times, as you'll see in a moment, delirium is reversible and preventable, though delirium may be persistent. So if one of your residents come in from the hospital or go from the nursing home to the hospital or to home with a delirium, it may persist for days, weeks, or months afterwards. The other reason I really love the story of Juanita, in addition to the fact that I think that it was a fairly good story that illustrates this, and she also was able to improve her quality of life after she got an assessment for her dementia and got those supports in place, is it really shows the power of the 4Ms framework. If you haven't heard about age-friendly care, though I bet many of you have, these are the 4Ms. So I think you heard in her story, and this is a real story with some details changed, that what matters was really a big part of her story. Medications, because she was on a high-risk medication that she could have easily been on a different medication, a lower dose, or had other treatments for that condition. And her mentation, of course, was integral. So not knowing that she had this dementia and that she was at risk for all these things to happen, and of course, mobility and function. So it's just a beautiful example, and I'm sure you have many others, of how these 4Ms have to work together because they all really are complementary. This is just another way to look at 4Ms and care transitions for persons living with dementia and delirium, which was Juanita, is how important it is to know the person. History, customary routines, and I'll show you some forms in a little bit. And I'm sure you have some that you might use in your facility. Mentation, knowing not just if they have cognitive impairment or dementia, but knowing what that stage is. Often people say, well, why do I need to know this? Because, there aren't a lot of medications to treat this, and we can also talk about that issue if we have time later. But the staging of it is so important to be able to give support and guidance to the person who gets the diagnosis, because they may live 20 years with the diagnosis, and also to be able to give support and guidance to the people in the nursing home that might be caring for them and their loved ones and their informal and informal caregivers, so that they can know these are the kinds of things that I'm going to see at this stage and at this stage and at this stage, and you can do some anticipatory planning. And of course, medications, sharing the medication list. I'm going to have a question in a little bit and ask you, how do you share this information when someone perhaps goes from the nursing home to the hospital, because that is really critical for someone like Juanita. And of course, mobility. I could talk all day about that one, but I'll say one word about that, especially for people in long-term care. And I'm there often enough to see this and to notice and observe and to be able to think about intervening. Is that did not mean to do that. Let's see if I can go back. Sorry. Helping people move every day, whether it's in their bed, in a chair. Someone needs to mute, thank you. Will have an immediate, and this is backed up by work by Wendy Suzuki, who's a neuroscientist, and other NIH work, have immediate effect on that resident's mood, mentation, and depression. Immediate. It will have an immediate effect on a young person that goes right now outside at the hub at Penn State and takes a walk. And it will increase their memory, their thinking, and their processing speed. And it will have a long-lasting effect in terms of preventing or delaying or slowing dementia, and also delirium. So now that I've talked about transitions a little bit, and I may not be able to look at the chat because I don't think I can see it right now, but we can save it and others can look at it, or I can look at it when I stop. But I'm very interested in hearing about the case of Juanita. How do you communicate this kind of information, particularly about mentation in both directions with acute care. So are they giving you, so if someone comes into the hospital and they have a delirium, do you know that? And do you know what the cause of it is? Do you know what their treatment plan was for that delirium? And also in the other direction, if you're sending someone to the hospital that has either intellectual and developmental disabilities or has dementia or cognitive impairment, how do you get that information? So if you could put that into the chat, that would be great. Maybe everyone at once, and we'll have a little waterfall of learning together. Do they have access to the chat? Because I'm not seeing anything in the chat.
They do. It just might take a minute
Okay.
to answer. Sorry.
Yeah, no, that's fine. It's a big question, and
It's a big question.
trying
I'll
to
type
put-
the question in as well. So if you move
Yeah.
on.
Yeah, no, I'll wait a little bit because I really would like to hear that response. Just put that in there and then press submit. Can you repeat the question? Okay, so someone says we call and we have a transfer sheet, great. So how do you communicate issues of mentation in particular, which is one of the 4Ms? How do you communicate that from the other side? And also, when they're coming to you, is whether or not they had a delirium, is that something they emphasize? Verbal reports, so hearing a lot of verbal. Great. I'm gonna keep going here. So I'm gonna talk a little. So I'm gonna go on and talk a little bit. I do not think there's a good understanding of DSD. Good. We're gonna talk about that in a minute. Delirium is greatly underrecognized, not just in long-term care, but acute care. We found that inpatient care teams in acute care only identify about 12 to 35% of all delirium. And from 1990s, when we began to get tools for this, we did see some improvement, but particular groups tend to not still be well recognized, and that are people with advanced age, people with what we call hypoactive or quiet delirium, people with pre-existing dementia, and it's not on this slide, I don't know how I kept that off, but people that come from a nursing home. And you're going to find out why in a moment. Oftentimes, if they come from a nursing home, they assume that this is their baseline. And then we also know that, and this is why I'll never stop doing this work, is that delirium identification promotes better outcomes, safety, and resident-centered care. Delirium occurs in about a quarter of general medical patients, but this goes up in special populations. So people with hip fractures, surgical patients are both closer to 50%. People with heart disease, 75% of people that end up in the ICU, and 90% of people with dementia will often experience some kind of delirium in the hospital. 40% of nursing home residents who come into acute care with either a delirium or a delirium superimposed on dementia from several studies. Again, we know that delirium can be persistent. It can lead to long-term cognitive function. This is a whole nother talk, but we know that actually repeated delirium causes dementia, and then having dementia makes you at much higher risk for delirium. So there's a two-way direction there. I really paid attention to what your outcomes were for this group. And so I'm going to say a little bit about some of those outcomes. We know that paying attention to delirium can impact several of those outcomes that were on that first slide that either Jill or Nancy talked about. So we know, you're going to hear in a minute, but that good delirium care can really impact falls and rehospitalization. We also know from a personal standpoint that delirium can lead to suffering. And undiagnosed dementia can lead to profound suffering. It also has a strong burden to nurses, care partners, and the older adults. In our current study, we're actually studying what we call delirium distress. Also, the other reason that this continues to be probably more important than it was before 2020 is that we are actually seeing, and I would love to hear whether or not you're seeing this in our chat and when we have Q&A time, is we're seeing an increase in antipsychotic use and a decline in non-drug approaches. So likely if you send someone to the hospital They're going to have a lot more agency nurses still, and I think I can say that with a lot of certainty. They're going to have more agency, they still have more agency staff. They're understaffed, and they're more likely to use antipsychotics and to be able to have less time. And it's not that they want to give bad care, it's that they are so poorly staffed right now. Also, during the pandemic, and I will say about the pandemic, because I have friends who worked in nursing homes and lost a lot of patients within a period of a couple weeks, is that delirium also seemed to be, because it was probably an inflammatory type delirium, was very severe delirium and very distressful to the people caring for them. And then the other thing that happened after the pandemic is that we're seeing a lot of long COVID issues with cognitive impairment that we're still trying to understand. So again, you might be seeing that in your practice. I'm going to keep emphasizing this idea of delirium superimposed on dementia, because oftentimes our brains, and I know as a nurse, I've often had even PhD students say to me, well, I kind of understand dementia and delirium, but I don't always understand the difference, and I didn't know they could occur together or that we could even recognize them. But it's very important because over half of hospitalized older adults with dementia will develop delirium. As I said earlier, about 90% will have some features of delirium. And dementia is the most common risk factor for delirium. I'll say that again. It's the most common risk factor for delirium. It's one of the most common that we see in the nursing home setting. And we'll talk about some of the other medical causes we see that are more common in long-term care. I have another chat waterfall that'll help me is, what is your greatest challenge with delirium? And so I want to hear things like, is it that you don't assess it, or you don't know what to do when it happens, or maybe it's not a problem. But what are some of the problems that you're seeing? Safety. Okay, I like to hear that, because we hear that in the home care setting too, by the way, that nurses feel a lot of stress and they're worried about their safety when someone has a hyperactive delirium, which by the way is the least common. Hypoactive is more common. But safety, I've heard that a lot. People think it's not a reversible condition. Thank you. Psych meds get prescribed too quick. Just in case I don't say this, there are no FDA-approved medications for delirium. Medication should be an absolute last resort. They do not help delirium, at least with the evidence we have right now, and they sometimes can worsen it. Recognition. Okay, great. So we're going to talk some more about these things, but I want to make sure I'm on the right track here. So a couple more things I want to talk about with recognition, since that's one of the themes I'm seeing from the chat, is World Delirium Day is coming up, by the way, March 13th. So you can use some of these ideas. And one of the things that we do is we have buttons that say, I care about delirium, think delirium, assess delirium, because the other issue, which, I know many of you have been working with older adults for a long time, so you may know this, but older adults have atypical presentations. And so this is just a perfect example. So to the left, you have things like pneumonia, heart attack, congestive heart failure, COVID-19, infection, depression, adverse drug reaction, dehydration. All of those things can present in just one way, and that would be a hypoactive delirium. So that's someone that's sleeping more, sleeping in their leather chair more, not getting up and coming to the dining room as much, not eating as much, sometimes very subtle things that you see. And what we saw in COVID-19, and this is published in the literature with data-based, is that older adults did not, in many cases, about a third, did not get a fever, did not have shortness of breath, did not have a cough. They had delirium. And so think delirium. Don't think dementia. though I want you to think about dementia in other ways. But when it comes to acute changes, because delirium can be a medical emergency. And I don't have time to give you all the examples, but I worked in my 20s as a clinical nurse specialist, my very first job with Terry Fulmer, some of you may know. And she put me in the emergency room because she was doing a study on elder mistreatment. And what I saw in that time was people would say, here, you need to help. I was paired with a social worker, and they're like, you need to help this person with their social issues because they keep coming into our ER. And there are several cases where it's like, yeah, they're coming into the ER because they have a delirium superimposed on dementia. And I remember one case where they had an infected thoracic aneurysm, and we were able to say, this is a medical emergency. This person is coming in, they're delirious. This is not their baseline. So it can tell you important things. Don't ignore it. I'm not going to spend a lot of time on this, but I want you to have it. This is, if you decide to do age-friendly care, this is their plan in the nursing home setting, is that you would assess delirium at admission and any change in condition. Well, what would that be? If they got sick, if they went to the hospital, and then in post-acute care, it's admission in every 24 hours and anytime they have a change. And you can find that online. So how do we detect delirium? So how do we detect it with an objective tool, which is really important, by the way. This is sort of what I call like the holy grail. This is Dr. Sharon Inouye developed this in the 1990s when she was working at Yale New Haven Hospital and started to see these cases of delirium. And this also comes from DSM diagnostic criteria. But the CAM, which is what a lot of the tools that I'm going to show you in a minute are based on, has 4 features for delirium. So think about these 4 features. That it's acute and or fluctuating. So it's new. Someone said in the chat, I actually pulled up the chat so I could see a little bit, but someone said, they call the family. Well, that's good, because sometimes families say, hey, and I know you've heard this before because I have, this is not my mom. My mom has dementia, but this is different. And then inattention, which is the hallmark of delirium, but can sometimes be hard to pick up when someone with moderate to severe dementia. And then disorganized thinking, which I'll be honest, has a lot of overlap with dementia. And then altered level of consciousness, which is really important because it doesn't have a lot of overlap. People may think it does, but it doesn't. So if someone's like suddenly, again, really sleepy, their function has changed, think delirium. If you remember nothing else from what I said today, because I'll say way too much, but think delirium, care about delirium. So I'm going to tell you a little bit about some of our tools, and there are many tools. There's a website called NIDUS, N-I-D-U-S, maybe someone can put that in the chat, but it has about over 25 tools, probably a lot more than that. They even have pediatric tools. But we wanted to find an easy way for nurses to assess this at the bedside. So I happened to be on my sabbatical at the time working with Sharon Inouye and Ed Marcantonio in Boston. And I said, I want to come up with one question. Yeah, so Nidus is in the chat, thank you. I wanted to come up with one question that people could ask. Well, that failed because one question only had about 80% sensitivity. What does sensitivity mean for those of us who may not be in the research world? Sensitivity just means the ability to pick something up, cancer, delirium, when it's really there. So we're like, well, we can't miss 20% of this because I just told you it was a medical emergency and it led to really poor outcomes, including death, by the way. I didn't say all they out, but a 25% increase in mortality, twice as long length of stay, really poor outcomes if you don't detect and prevent delirium. So we did find a tool, which we tested with a lot of data. We have about 11 papers based on this. And the really cool thing is we had nursing assistants do it. And nursing assistants were able to do this with over 90% sensitivity. We've done a couple of we did a pilot study, then a larger study. In this particular study, we had 110 nursing assistants. They also did it quick. So most of them did it actually in about 36 seconds. And I actually helped train some of the nursing assistants, and I'll tell you, they picked up on it really quick, and the training only took like 5 to 10 minutes in most individuals. So this is called the UB2. Now, the problem with the UB2 is it's very sensitive, but it can have false positives, especially if someone has delirium. And so what often we do is if they pass the UB2 fine, I have something I call a strength-based assessment. And I've always done this when I worked in the hospital as a clinical spec, is I write first the things that they can do, right? And I bet people on this call appreciate this, that, it's so easy to say what people with dementia can't do, but we know that they can do a lot of things too. And it's the same thing with delirium. When you pick up delirium, it's like, okay, they can follow a 3-stage command, they can do this, but they had problems with the test of attention. I want to point out, for please tell me the day of the week, they can look at the whiteboard, they can look at their cell phone, they can look at their newspaper, because we're not trying to pick up dementia, we're trying to pick up delirium. And people with delirium won't know to do that. And then you have the test of attention, the days of the month backwards. This is the full tool. So if someone doesn't pass the UB2, you'd go on to do the rest of this tool called the UBCAM, which I'll show you how we tested it. I have a link in this chat, and you'll get these slides about what we're doing next. Now we're now implementing this. We'll have data on over 20,000 older adults. You can scan the QR code if you have a phone. It also works for Android, and it's free. All of our work is free because we want to disseminate it. We want people to use it. We want people to improve care. So this is an app that you can download and use. And I know there are some nursing homes in the IHI Action community that are using this tool. I also wanted to show you to the left. That's what it kind of looks like. I think we've changed some of the colors there, but that's pretty much what it looks like. The other piece about this is which is coming very, very soon, is we have treatment and prevention screens, because someone said, oh, they don't take it seriously. So this gives you some things like, if you're waiting for the doctor to call back, or the NP or the PA, whoever, you can say, these are some things we can be doing right now to think about this problem. And we also have prevention tips. I did want to show you this data. Again, look at this. This is our very first pilot study. Nursing assistants with the UB2 had 100% sensitivity. So they picked up delirium 100% when it was there every time. Nurses in this study picked up with the 2-step protocol, which is the full tool, 100%. Big surprise. I don't know. They did better than physicians. I will tell you, in the larger study, this was just a feasibility. In the larger study, nurses and physicians did about the same. They both had good accuracy. Okay, here's the next one, and I hope that you can take a minute to answer this. And some of you already did answer it earlier in your thing. But do you think you can easily detect delirium in persons with dementia? Yes, but only if I know them really well. Yes, 100%. No way, not sure. Can I phone a friend? So those are the options. I guess I could have done a poll, but I'm not that techie. Hopefully we'll save the chat. Not sure. I see a not sure. I definitely can relate to that. I love this to be interactive. I hope this is helping you think about the problem. If I know them well, great. I've heard that before. Depends on the person. Yeah, I agree sometimes, actually, and we can talk about that. Okay, I'm going to keep going, but keep doing that. So now I'm going to tell you some data, because that, I am a researcher now. I mostly spend my time doing clinical research and some consultation for behavior in persons with dementia and delirium, but most of the time I spend doing research. I'm going to talk about some research, but it's clinical research. This is what we call implementation, real-world research. So we studied over the last 5 years, 527 older adults in the hospital with a mean age of in their 80s, like 83. So they were older adults. And we had 900, almost 1,000 days of assessment, because we assessed them for 2 days. Here's the part I want you to see in red. over a third of them had dementia or ADRD. The other thing is with this, again, this was an implementation study. So we just handed an iPad to the clinicians and said, here, do this assessment. Again, they had almost 90% accuracy. They were able to do it very quick, and you can find these results online. What I wanted to show you, though, to get to the dementia question for long-term care, is that when we looked at people with dementia, their accuracy did fall a little bit. And so it went to about 80% accuracy when someone had a dementia. I'm not sure I'm showing you the right slide there, but their accuracy fell a little bit, but it was still, 90% with none at all and very high 80%. But then when we went to clinicians, the same clinicians that were picking up delirium superimposed on dementia using this tool, so they were picking it up pretty accurately. We asked them, can you pick up delirium in people with dementia? And almost all of them said no. And we had the following themes. Again, you're going to have these slides because I want to have time for questions. But a big one was they would chalk up any changes or mental status changes or behavior to dementia instead of saying, let's think about whether this is delirium. Some of them, like in the chat, said it depends on the stage. And that actually is right, because we don't have, our data was people with mild to moderate dementia, and some of these tools don't work in someone, for instance, that's nonverbal, but some of those people are also at their end of their life. The other thing, and I love this because it came up in the chat and shows how, close all of you are to care, is that they said knowing the person or having time to know the person was important. It would make it easier. So I wanted you to know that we sort of it's called mixed methods, but we put the two types of data together. It's very interesting. And so now we're going to use that to think about how we can get people to pick up delirium better in people with dementia, which is one of my areas of passion. I also say another group in long-term care that this may apply to is people with intellectual disabilities. And there are tools. The tool I like the best is the National Association of Down Syndrome. And if anyone has an interest in this, I'll send it to you. But they have a table that helps you think about someone with IDD and whether or not they have an acute change or a dementia. I also wanted to show you this. Nursing assistants love the delirium screen, and that was pretty universal. And they said things like, I could do this. I could do it when they give them, get their blood sugars, or we do their vital signs, and saying like, look, I'm often one of the first people to notice because I'm the one that's closest to taking care of the older adult and at the bedside. So I love that we got interviews with nursing assistants. This is another tool that some of you might use that can be used, especially in the non-post-acute setting in long-term care. It's called Stop and Watch. And I bet some of you know about this tool, but many of the questions in Stop and Watch, if I were taking care of someone and they had some of these issues, I would think delirium, and then I might go on to do like the UB2 or the UB-CAM. So I think this is a great tool, and it's backed by evidence, and you might be familiar with it. So let's jump in a little bit to like what you do about this problem. And I'm going to come back to one of your first slides that Nancy put up about outcomes. Prevention right now is more effective than treatment. We have a lot more data on what you can do. This was a 2015 review, and it has been updated, but 11 out of 14 studies that did these things: cognitive stimulation, hydration, getting rid of high-risk medications, not starting high-risk medications, stopping them if they come to the hospital with them. A big thing that happens is people come to the hospital, they see these behaviors, they put them on the medications, and they don't take them off. Early mobilization, daily physical activity. This is one of the things we have like for hydration to encourage people. We also have cognitive stimulation. I think this is the Pennsylvania Railroad. So stimulating people when they're in the hospital. And then vision and hearing enhancement. Studies have actually shown that hearing loss leads to dementia, and it's a reversible cause of dementia and delirium. But the one thing I want to tell you is one of your outcomes that you care about is falls. And I know, in acute care, everybody calls about falls. In these studies, those studies that did study falls while they were doing this delirium prevention, they had a 62% falls reduction. I'm going to say that again. They had a 62% falls reduction. Good delirium care, good age-friendly 4M care will reduce falls. And then what if you do all these things and they still get delirium? This is a great, again, it's more of a resource for you to have. There's sort of 4 steps if someone comes to you with delirium. Hopefully if they're coming from a hospital setting, that they've already treated some of the causes, but maybe not, because those causes might, like in the case of Juanita, they might be multi-causal. So looking for calls, treating the calls, and you'll see some listed in this table that you'll have. Preventing and managing complications, that's really big, because people that get delirium, they fall, they aspirate, they get pneumonia, they get skin ulcers. So you want to avoid those complications. One of the biggest ways that they get complications, by the way, is that people mismanage it. So I tell people, don't assess delirium. Do not assess delirium. I can't believe I'm saying that. But do not assess delirium if you don't have best practices in place, because you might be doing more harm than good. So if you assess delirium and you're going to call your on-call doc and they say, give them Haldol, then don't assess delirium, because you're going to make them worse. Or give them Ativan, which will cause them to fall and make their delirium worse. And that's evidence-based. And then lastly, people that have delirium often end up spending a lot of time in bed. And so you have to think about restoring function. And if they're coming from if they're going home again, discharge teaching and caregiver support. These are some of the most common causes of delirium, not at all exhaustive. I mean, there are other things like hitting your head, and someone that's an older adult can hit their head on the kitchen cabinet. If I do that most of the time, I'm like, oh, I'm fine, that really hurt. But an older adult, because of the fragility of those blood vessels and the space in the cranium, may have a chronic subdural that might cause a delirium. So there are many causes, but these are the most common that I present to you. And I highlighted in yellow some that the literature in long-term care is not great. So if you're looking to do a study or quality improvement, this would be a good area. But if you're looking at some of the areas, some of the most common causes in long-term care in nursing homes, medications, especially anticholinergic, especially any central nervous system or anticholinergic medication, infections, especially respiratory. UTIs are often overdiagnosed, by the way, so think other things. Dehydration, and then fecal impaction, believe it or not, is a really big one. And then of course pain and sleep deprivation and impaired oxygenation. And again, this is not an exhaustive list, but some of the most common. This is just an algorithm I want you to have, which also talks about sensory impairment or sensory overload, immobility, interrupted sleep. And it talks about some of the things you can do. And then things like having sensory aids, non-drug alternatives. There was a study actually by Chris Wazinski that's at Hartford Hospital that actually showed people who have a hyperactive or agitated delirium is just having a 1-minute video from a trusted family member or friend helped calm them down and helped avoid having to use any kind of medications for them. Again, there are no FDA drugs approved. Medication should be an absolute last resort for both dementia and delirium, and only if they are in danger of hurting themselves or others. And I also say, sometimes we'll say, well, we tried this. It's really trial and error, which I'll show you in a minute. The other thing I like to say about this problem is that all behavior has meaning. So the other way that a lot of older adults get in trouble or get delirium, so those who have dementia, is they present with a behavior in the hospital setting, and we don't recognize that it's a delirium, or we try to treat that behavior with medications instead of saying, what are their needs? What's going on here? Do they have to urinate? Are they in pain? Do they have delirium? Are they fearful? Are they misinterpreting stimuli because they're not in their home anymore? Now they're in the hospital. So thinking about all behavior have meaning. These are in terms of what matters. The other piece of behavior is knowing the older adult. And I know that you do some of this already in the nursing home, but these are some questions. And I think you have to simplify some of these questions for people with dementia, like what makes you feel calm? What makes you feel happy? Who brings you joy? Who are the most important people in your life? If you can share some of this stuff with the hospital setting, you've done all of us in the hospital just a big service for us to be able to know this person as a person, because in the hospital they see this person that might be disheveled, have a hospital gown on, and they forget about them as again, as my son would say, as a human. This is a real case, which the person said I could use, but this person again went from the hospital during COVID-19. They weren't allowed at the bedside until we actually helped them get at the bedside. That's another story. And then they went into acute rehab, and then they went into long-term care where they passed away. But she happened to be an instructional designer, so this is what she sent with her dad. And if you want a template of this to make your own, I have it. This is another form called All About Me. Again, you'll have it. This is a great toolkit called Behavior Symptoms of Distress, the Nursing Home Toolkit. And you can actually put in things like vocalizations. Again, I'm switching a little bit here to behaviors, dementia behaviors, because sometimes we mistreat them as a delirium. This is another approach which I love called the DICE approach to behavior. So again, looking, is what you're seeing, investigating the cause of what's happening here. Is this a delirium? Is it pain? Is it medication? Is it sleep problem? Is it fear? Is it boredom? Is it caregiver expectations? And then it walks you through ways to create interventions. And again, this is evidence-based. This is another one I love because DICE can take some time. And this one's called ta-da, like ta-da. And so it's, can I tolerate this behavior? And most of the times we can. Can we teach staff to step back, breathe? I actually wear a bracelet that says breathe. So get them bracelets that remind them to breathe because I know it can be hard when someone's swinging at you or agitated. So stepping back, can I tolerate this? Can we use some distraction techniques? And I didn't give resources, but there's some great people out there, including someone called Be Light Care. She's a speech therapist and she has tons of stuff like that. The other is don't agitate it. Do not make it worse. Do not escalate it. And then I added an A which is ambulate, because oftentimes that will help if they can ambulate. Also think about drugs to avoid. This is the 2023 criteria. So look at their drug list. Are they on any of these? Did they come from the hospital on some of these? Could it be these? And it can be these medications, even if they've been on it a long time, it can still be causing it. Again, this is just a resource because I want to stop with 10 minutes left for questions. But my colleague, Nikki Brandt, and other colleagues, and I also participated in this during COVID-19, is they came up, and there's your website, but they came up with a way to try to minimize medications in long-term care. So looking at those that are often unnecessary, aren't really providing clinical benefit, but we've always had people on things like iron and multivitamins and herbal medication. Thinking about reducing the frequency of medications and changing time of dosage. And also, again, going back to the Beers criteria, just taking them off medications that are harmful to them that should be avoided if at all possible. I also realize that sometimes we can't just take people off medications, and that's a whole nother lecture, but thinking about offering alternatives. This was one, it's an old reference from 1998, but actually doing these kind of things in the hospital. decrease delirium, and decrease the use of sedative hypnotics in older adults. So just going back to our case, thinking about, asking what matters to people, knowing that behavior is a form of communication. So thinking about this what matters piece, the less medications, the better. When deprescribing medications, high-risk medications, we've actually found that there are some phrases that work better than other, and they tested these phrases with older adults. So if you tell older adults, well, this really isn't going to benefit you because you're so old, they don't like that. But they would like it if you said that, this has bad side effects, and you might not be able to keep doing the things you want to do if you stay on this because it causes you to be too sedated and to fall and not be able to do the things that are important to you. So again, connecting it back to what matters. This I just want you to have, because I know you're going to say there are barriers to these things, and there are, but there also are solutions. So this again came from data from staff about things that we could do. What are some of the barriers? High workload, low morale. So what do? We align it with their clinical ladder. We reward and praise them. We do huddles where we think delirium. Think about celebrating World Delirium Day that's coming up. Align it with their scope of practice. The other thing is, we often apologize for assessing people's mental status. So don't apologize. Think of it like a vital sign. Use humor. Again, just some more. Hypoactive's really common. They also might have physical changes like I feel confused, slumping posture, their eyes looking different, and there is some research being done on that. We do have some online modules for nursing homes, and we give CME, and it's free. So I want you to have these resources. Again, just these are resources for you to know. We have a series called Living with Dementia. We have flyers that we've developed for each county, our surrounding counties in Pennsylvania for the 4Ms. And I'm going to stop here because you're going to have these slides, but I just wanted to give you an overview and tell you that there are a lot of resources out there for delirium and leave you with some of these tips, and I'll stop.
Donna, that was really terrific. There are a tremendous number of resources here, and there's a theme that runs through here. You'll notice age-friendly health systems is here a number of times. Donna works nationally also with the age-friendly health system resources. I encourage all of you to look at age-friendly health systems and see whether or not you want to join the new action community that's starting this spring or the one that's starting in the fall. They just provide you with a wonderful array of resources focused on nursing homes, focused on the care that you are aspiring to provide to your residents and to engage your staff in a meaningful way. I did a little vamping. Does anybody have questions for Dr. Fick? She certainly has access to some of the best resources, and for those of you who will get this recording as well as the slides, you'll see them. Let me read this to you, Donna. Have residents who has 3 to 4 days no sleep every 3 to 6 months and becomes delirious, uses trazodone to reset sleep. Not sure if we should keep on trazodone to prevent recurrence. Is it worse to just use for a period of time?
Yeah, I don't prescribe trazodone, so I don't know if I can really answer that, but I can connect you to some people that I think actually trazodone is that, not just think, but trazodone is one of those that are sometimes used that are less harmful. And if you're sure it really is a sleep issue, I think the only other thing I'd say is sometimes it's multi-causal. So thinking about whether or not there are multiple causes, but trazodone is sometimes used effectively for sleep. And also thinking about cognitive behavioral therapy for sleep, because trazodone can also cause falls. So it's I'd never say stop a medication without knowing that person. Clinical questions, unless you know the whole story, you can't really answer. But I'll say in general that sometimes trazodone can be used effectively that way. But I'd also make sure that it's a last resort, that you've tried other things first.
And here's another question. Do we treat the symptoms, not the disease?
Do we, or are we?
I'm reading.
Yeah, so so in dementia, we don't understand the underlying pathology and disease yet. And so oftentimes we are treating symptoms, and we want to make sure we're treating them in a way that, like I said, all behavior has meaning. What stage are they at? How can we support them? Now with delirium, I'd say it's different. With delirium, we can usually find that cause. And so I'd say we're treating the condition, not just the symptoms. I mean, if they're having behaviors, you want to make sure you're responding to those behaviors in a way that's not making them worse and giving them those complications like falls. But you do, when I showed you those 4 steps, the first step is treat this condition. What's causing it? You know, is it an infection? Is it just that they're in a new environment? Is it a new medication, which is a big one? Is it a combination of dehydration and a new medication? And so I talked about dementia and delirium both, and hopefully that didn't confuse you, but I think you have to in a long-term care setting and a hospital setting.
Thank you so
Good
much.
questions.
It was an excellent presentation, and the resources are just going to be so valuable to all of these different communities that are struggling on a day-to-day basis with the issues that you raised today. We are so grateful to have the Pennsylvania Long-Term Care Learning Network and its sponsors, the managed care organizations and the Department of Human Services, because where else could we bring you such incredible speakers and incredible information and have you not have to leave your facilities in order to get this information? Just have to make sure that you put on your calendars every Thursday at 2. Come on here and we'll make sure that we can give you information that will be valuable to you and actionable. I'm going to do the few last remaining announcements. First, I want to thank Dr. Fick, and I also want to thank Jill Bavakis for being here today. If you are here from a personal care home and assisted living residence, we are delighted you are here. Jewish Healthcare Foundation will not be providing you with a certificate. There's information on the screen as to how you can refer to your regulatory compliance for how you can document this training. And we have our next 2 webinars. First, I want to remind you that at the end of March, we're going to have our next learning collaborative, and it's a great opportunity for any of you who have best practices on particularly transitions of care, which has been what we have been talking about this quarter. We would love to hear from you. You don't have to do 40 or 45 minutes. We're looking for 10 or 15 minutes of a promising practice, something you are doing within your community or something you struggle to get done within your community that could be of help to others to learn from you. So please, Stacy Bonenberger from the Jewish Healthcare Foundation staff is always looking for those of you who are eager to come forward and share with other colleagues. We just know how valuable that peer sort of learning can be. Next up, we have 2 webinars coming. The 22nd next week, we have strategies to reduce hospitalizations and ER visits. Then you get February 29th off. It is a leap year. You get that day off to do whatever you choose to do, but as the 5th Thursday of the month, we won't be here. But we'll be back on March the 7th for opioid use disorder in long-term care. Incredibly interesting and important topics with great speakers. Please mark your calendar. We tell you these in advance so that you can bring the right members of your team to the various sessions. You are always welcome, but you're always welcome to bring others with you as well. With that, we're going to close it out and say thank you to our speakers. Thank you to all of you for what you do every day and for taking the time out to be here to learn how to improve and change services that you're providing on behalf of the residents that you serve. Thank you all so much and have a good rest of your day and week.